Good evening all. I think we're ready to kick off now on the final parallel session this afternoon.
Yeah.
I do realise there's a bus heading for town at 6:30, so we'll hope to have you out of here by then. But before that, we have some very, very interesting speakers who'll be speaking generally around an area that I personally think is hugely important in terms of the type of skill sets, education, training that those care workers and allied professionals who are working with people with dementia, what they should have, etc. You'll probably notice my voice is a bit strained at the moment, but if you looked at my bio, you might have seen that rugby is one of my passions. And I was in Paris for the weekend and I shouted way too much, but obviously it didn't help because we were beaten anyway. But my voice is struggling today as a result. So less from me, and we'll go to the first presentation, which is Dr. Stephanie Daly, who's a reader in mental health and dementia at Brighton and Sussex Medical School. And she is accompanied tonight by Chris Maddox, who is a person living with dementia, but also, very, very significantly, the first person with lived experience who has been appointed as a trustee to the Alzheimer's Society in the UK as well, which is quite significant. So without further ado, I will hand over to Stephanie.
Okay, well, thank you for coming this afternoon. Chris and I are together. We're going to tell you a bit about Time for Dementia, where Chris is going to speak about her experience of taking part, and then I'm going to talk through some of our outcomes. I want to highlight that I've got a colleague, Colin Capper, in the audience, and that Time for Dementia is delivered in partnership with the Alzheimer's Society. So there's only room for two of us on stage, but actually it's a much bigger collaboration. So just to start, so Time for Dementia, it's a what it does, or what it involves, is longitudinal contact between healthcare students, a person living with dementia and their carer. And within Time for Dementia, the person with dementia and the carer are the expert teachers. They are the experts on dementia. The students visit a family, so person with dementia and their carer, in their own home, and two students go to see one family 3 times a year over a 2-year period. The programme is a worldwide first in terms of the range of healthcare professionals involved, and also being delivered as a mandatory component of the undergraduate healthcare education. And within the UK, we've had 8,000 healthcare students do the programme, and the Alzheimer's Society have recruited 2,100 families to take part in the programme. Currently in the UK, it's being delivered across 9 different universities, and we have 10 different training programmes. So it started off with medicine and nursing, and it's now being delivered to a much wider range of programmes. And within the programme, we have an integrated programme of research. So we've been using the research findings to continue to develop the programme and to use that to expand the programme. So I'm going to hand over to Chris, who's going to talk about her involvement in seeing students and being part of the programme.
Thank you. It's a pleasure to be asked to come here to speak. I've got 3 questions. The first one is, why did I take part in Time for Dementia? There are so many reasons, but I have only got 4 minutes. So I want to raise awareness of dementia, negate stigmas, help others in the diagnosis process. And if I can help just one person to not have to go through some of the negative experiences that I went through, it's worthwhile. And I just want to start off by saying that it's hard getting a diagnosis in the first place, especially when you have early onset dementia. And I had some minor strokes in my 50s, and I was diagnosed with vascular dementia when I was 60. But trying to get my diagnosis was so hard. I went to my GP, who told me she was there for my physical health and not my mental health. I left there in tears, and I didn't know where to turn. That was so wrong. Please change the way that you deliver the diagnosis to us. My diagnosis was, you've got vascular dementia, go and get your affairs in order. And so many people have been given their diagnosis like that. Where's the hope? What gives us a sense of purpose in our lives? I lost my job when I got my diagnosis. I need some hope. And especially when you're younger, you need something, a sense of purpose to keep on going. And there've been occasions when I've gone to a medical appointment, and as soon as the medical practitioner knows I have dementia, they talk to my partner or the person I'm with, and they don't talk to me. And I now say, excuse me, but you're talking about me, so please talk to me. And I've had a very same experience with a friend of mine who is at end of life and recently passed away. And the palliative care nurse kept talking to me and not talking to my friend. And I stopped her and said, that's not right. So give us some hope, please. When we have our diagnosis, say, well, there's some things you may not be able to do, but there's lots of things that you can still do. My second question is, what has it been like taking part? Whilst I've been taking part as a person living with dementia, I've also been part of the advisory group at the university as an expert by experience, which was really important to me. They're not using so many synonyms and acronyms now, because I tell them off, because I can't understand what they're talking about. Face-to-face visits were really effective, as I could also read the person's body language. And we did go on to Zoom visits during the pandemic, but it was good, but not as good as face-to-face. I felt it was really worthwhile. Taking part of this has given me a sense of purpose. And in fact, I had a visit from two third-year medical students on Friday. And the one thing I have said to them, please don't refer to me as your patient. I'm not your patient. I'm an expert by experience. And what difference do I think it's made to the students that have visited myself and my partner? They've all said that they can learn from the books. They can learn from the lecturers, but they can only learn so much. They can never learn the true effect that dementia has on the person diagnosed with dementia and their caregiver. So spending time with us is the only way that they can find out truly how dementia affects me and my partner. And it gives them an understanding of lived experience. Thank you very much.
And as Chris has said, we can't teach our students what that contact with Chris and her partner and other families taking part. So this does something that other parts of the curriculum doesn't do. Very briefly, I'm just going to talk about some of our findings. So we've been doing this programme of research. So we've looked qualitatively with focus groups and interviews. We've seen about over 90 students from a range of backgrounds. And from that work, they've highlighted to us 5 key themes that the programme gives the students. Firstly, it's a much broader, much more in-depth understanding about dementia. Secondly, that the learning takes place in the context of an authentic relationship. So it's not just delivered, as I was mentioning, in a classroom. It's in the context of, a meaningful relationship, say, as Chris has been describing with her and her partner, so it stays embedded. It's much more powerful than what we can teach. It challenges attitudes. A lot of our students have very negative attitudes about dementia before starting the programme. And again, seeing what people can do, understanding that you can make a difference at all stages across the dementia journey is really powerful for the students. Students are able to think beyond just signs and symptoms and think about psychosocial matters and what helps with coping. And finally, students are much more confident in their practice. They're much more confident in their communication with people with dementia. And they often describe feeling quite scared about working with people with dementia before the programme. So this gives them that experience in a very safe way to build those skills. In terms of, I'm just going to very briefly, and I'm mindful of the time, but talk through some of our quantitative outcomes. So we've been collecting data since we started the programme back in 2014. So looking at longitudinal data, both baseline and follow-up. We've had 24 intervention groups of students with 8 groups of control students, so students not doing the programme, and recruited just over 3,000 students at baseline and have followed up 1,451 students. And we've looked at dementia knowledge, attitude and empathy and satisfaction. And basically, when we've looked at those 2-year outcomes using a linear regression model and allowed or controlled for baseline scores, demographics and COVID disruption, what we've seen is statistically higher levels of change or improvement in dementia knowledge and dementia attitudes in the group doing time for dementia. Also, when we've looked at the number of visits students do, which we've collated, so again, looking at 2-year outcomes and looking at the number of visits, again, allowing for those same variables, what we've seen is a dose-response relationship. So we've seen the higher the number of visits, the better the outcomes are in terms of dementia knowledge and dementia attitude. So really encouraging results. In terms of our next steps, and this is a real whistle-stop through, 9 years worth of work here, but we're just about to be delivering the programme in 3 new universities in the UK. We're looking at delivering the programme as an interprofessional module, so having professionals from different groups going out. We're looking particularly to develop in Wales and Northern Ireland. We're continuing with the evaluation, looking at funding and our funding model, and really wanting to raise the profile of the programme. So super quick whistle-stop tour. This is the whole team involved in Time for Dementia here. And if you would like more information, do follow us on Twitter or on our website. So thank you for listening.
Thank you very much. Sorry, Chris, my apologies.
I just noticed we got another 3 minutes. Can I say something else? I just wanted to say that the other thing that we did is that a lot of the students are very young, and they were very fearful about going into the home of people living with dementia, because they didn't know how to speak to us, they didn't know what to say. So Steph and I did a film talking about my experience of dementia and to ask us any questions. And I finished it off by saying we give good biscuits and tea and coffee, and the gin stays in the cupboard. So this helped the students because they can see this film before they even go to the homes, can't they?
Yeah.
So it's worthwhile to do something like that, just to give the students some confidence before they even come out, because they've never met people living with dementia, and a lot of them still have this assumption that you living with dementia, you can't communicate and you just sit in the corner quietly. Well, they haven't met me, so thank you.
Thank you very much for that presentation, both Stephanie and Chris. And I think we have maybe time for one question from the audience. We have someone in the front.
Sounds amazing. My first part of the question is, are you recruiting at the university? So I work for Birmingham University. We'd love to be part of this. I know that 100%. And secondly, are you looking to bring this to non-healthcare related programs? So I think, and is that the interdisciplinary part that you were talking about? So I think even like history.
Oh, that's like, thank you. Hello. So I think even like all other programs would definitely benefit from this, because I think it's just about understanding how the whole world and people living with dementia access the whole world, and if we can like actually make the whole world more dementia friendly, I think, and everything dementia friendly, would be really useful. But yeah, look, sounds absolutely incredible.
Thank you. And I'm just going to answer. At the moment, our target is the future healthcare workforce, so it is about having it delivered at lots of different universities. That's our target. But it's interesting what you're saying about, we've realised, I think, quite recently that it also serves as an anti-stigma sort of programme, which wasn't perhaps its initial intention, but it does a lot more than just what it says on the tin, so to speak. So maybe in the future, but and we'd love to come and work with you at Birmingham.
So would I, Phil. And also, people living with dementia can learn new things. They say we can't, but we absolutely can, given the right situation and surroundings.
Hello, Evie Cizo from the Netherlands. I'm also a teacher and I teach also medical students. So I was wondering, how do you evaluate the program, how the students have learned, what the students have learned? Do you have some sort of exam or do you provide feedback? Christine?
Yeah, so different courses do different things. So where I work at a medical school. So what we do in the first year of the program, that the students do an assignment, so a reflective account, and that's assessed as part of their program. And so they do that in the first year of the program. They have to do a minimum number of visits to pass the year. And in the second year of the Time for Dementia program, so their third year of training, they have to do a reflective piece that their personal tutor signs off. So it's less about, I guess, academic learning and more about the sort of shift in thinking and attitudes and knowledge. But it's absolutely embedded within the curriculum.
Oh, great. And for you? Do you provide feedback to the students?
For me or Chris, you mean?
Chris, I mean.
So do you tell the students what you think?
I'll tell them whatever they want to know. But I was talking to one trained doctor who'd done the Time for Dementia programme, and he was walking through a ward, and there was a lady very distressed, and staff were surrounding this lady and about to call security. And he went over, got down to the lady's level, spoke calmly to her, and she calmed right down. The worst thing they could have done was call security. And he had done the programme, and he really helped that lady out.
Great, thank you.
Listen, thank you once again, Chris and Stephanie. Thank you. Please put your hands together. We'll go straight into the second presentation now, which is from Marlies Veenstra from Netherlands, and it's around the implementation of an observational pain assessment in a nursing home staff working with people with dementia. So, we'll hand over to yourself.
Thank you. So, hello, good afternoon. I would like to start with a question for you, and my question for you is if you would like to stand up for me, please. If you are able to, of course. Okay, thanks. Okay, and then would you please, this is for me, just to get to know you a bit as an audience, because then I know where to put my emphasis on with my presentation. But would you like to sit down if you are actively working in the nursing home, for instance, as a physician or a nurse or psychiatrist or paramedics? Okay, a couple of you, thank you. And also please sit down if you are actively working on research into dementia patients. Okay. Yeah, there are lots of other people. And then for the people who are still standing, maybe you are interested in pain or implementation research, then you can also sit down. And for the people who are still standing, I think maybe this presentation is not that interesting for you, because I really wanted to tell you something about our implementation study into pain assessments. My name is Marlies Veenstra, and I'm here on behalf of the Collaborative Academic Network of Nursing Home Care. And this is, I'm working for the one in the northern part of the Netherlands. And the study I'm talking about is conducted in 2 of our collaborating nursing homes, which were 20 in total. So, as a background, as you, I think, all know, the prevalence of pain in older people with dementia is quite high. That is partly because of, with the disease, there are neurodegenerative processes that occur in the brain. And this influences a person's communication skills. So, for instance, also the expressions of pain might alter when people got dementia. So pain can, for instance, lead to changes in behavior, for instance, like aggression, agitation, apathy, depression, but also changes in habitual behavior, like walking patterns, but also eating habits. If there are changes, this may indicate that people are in pain. So do due to these changed expressions in people with dementia, adequate recognition of pain is sometimes challenging for nursing home staff. So, and as you can see here in the figure, which is of Anne-Laure van Dalen, you can see that pain, dementia, functional impairment, and challenging behavior is connected, and it's a quite complex situation. And unfortunately, in practice, the expressed behavior that is visual is often treated mostly, instead of that it's been seen as an indication of discomfort or, for instance, pain. So as a result, the prevalence of pain in nursing home residents is about 40 to 80%. And the estimate is quite, it's a wide range, so there's a high inaccuracy. And this is, it has to do with that there's no gold standard for pain in practice, for assessing pain in practice. But it's not without reason that, for instance, in our guidelines, the first thing to do when there's a change in behavior, the advice is to check whether a person is in pain. And the pain assessment in impaired cognition, of the PIKE 15, is one of the things you can do that with. And this was an instrument developed by an international team of physicians, for nurses, and other experts from the field, and also people with dementia were involved. And it resulted in a scale of, in total, 15 behavioral descriptors that were like the best behavioral descriptors of pain expression. And it has 5 facial expressions, it has 5 body movements, and it has 5 vocalizations of pain. And the scale is scored while a person is being observed for about 3 minutes, and it can be in rest, but it can also be during activities of daily living. So that about the background a bit. We did an implementation study, and we aim to evaluate the process of this structured implementation of the PIKE 15 on behavioral change of nursing home care staff. And we did that by the behavioral change wheel. And as many of you are researchers, I think this may be interesting for you as well, because the behavioral change wheel is a method that comes along with a guideline in which you can stepwisely go through the process with your project team, and then you can stepwisely develop like targeted strategies to reach the desired behavior. And you start by selecting the desired behavior, your target group, you do a behavioral diagnosis, but that means that you do a survey among your target group. In this case, it was the nursing home care staff. And then you select interventions, policy options, and you develop your own strategies. And that's all done before you started implementing your thing, your strategy, and to evaluate, finally, of course. So our main target behavior was that we wanted to, it was like the project team wanted to consistently screen for pain using the PIKE 15, and that should be done by nurse assistants, licensed practical nurses, and registered nurses. And we did that. So we did a survey after that to do the behavioral assessment, and we did that in 2 locations. So one is a quite big location with 6 locations, 9 departments, and 274 beds, and the other one was smaller with 1 location that participated 6 departments and 54 beds. So this is the results of the survey we did. And this is just some examples of questions you can ask based on the model that's underneath the behavioral change wheel. So for instance, we asked the care staff whether they know why identifying pain was important, and that is to get a picture of their capability concerning pain assessment in people with dementia. We also asked whether their organization got sufficient resources and we asked for motivational aspects, like screening pain is easy for me. That is one of the motivational questions one of the questions you can ask to assess their motivation. And what you can see here is that before the start of the total project, people scored very low on capability items, but also on motivational items, and in one participating nursing home, also the resources were not enough. So that's why we developed some implementation strategies, and to increase the capability and motivation, we developed group lessons for employees. We made an e-training of the PIKE 15 to make it available for the nursing home care staff. And we appointed pain coaches, which were like role models. They were working at the sites and they were experts in pain, so they could be like, they could help when there was a question, or they were role models. We created a decision flow chart, and we integrated the PIKE 15 into the electronic health record. So this took us about 3 months in total. After that, we started with the training for the staff, and then we evaluated that again with the survey. Then we started with the actual implementation phase, which took, in theory, 6 months, and then we evaluated it with the focus group, with a survey again, and with the focus group. And I show you the results of the survey first, and after that, the results of the focus group sessions. So the survey, you can see here, after the training and education, so that was T1, you can see that the knowledge and the motivation to use the PIKE improved. But after the implementation, the importance of identifying pain was still high among employees, but they found it difficult to assess or to keep track of the pain of the PIKE in practice, and other tasks sometimes have priority than assessing pain, we found. And then the focus group discussions, we held it in both nursing homes, and the largest nursing home, we had 11 participants with different backgrounds, and in the smallest nursing home, we had 5 participants with different backgrounds. And what they said is actually a bit the same as what we found in the survey. So they found improved knowledge when to screen for pain, and they said that the PIKE 15 really helps in identifying pain, but still they found it hard to interpret the results of the PIKE 15. And that has something to do because of the PIKE 15 is not a diagnostic instrument which says you that a person is in pain, but it is like a screening instrument that tells you whether there might be a risk or a high risk that someone possibly is in pain. So it is like a starting point, and it's not an end point, and it makes it hard to interpret the results of the screening for nursing home staff. And although it takes only 3 minutes to screen for pain or to observe pain with the PIKE 15, it still takes time, and you need to make time for it to assess it. So that was what they gave us back. And we also evaluated the deployed strategies. Yeah, I'm fine. So the pain coach, so the role model, was evaluated very positive, as well as the e-training and putting the PIKE 15 in the electronic health record. The clinical group lessons, which was provided by the pain coaches, was not that positively evaluated, but yeah, some people followed, some people did not, so maybe that was the reason. And the flow chart was less positively evaluated, but they say like, well, I know that it was there, but I didn't use it that much, I didn't look at it, but we don't know whether there may be some implicit learning here, because it could be that people used it in the beginning, but after a while they don't use it anymore, but we don't know that for sure. So a take-home message is that even, also in implementation studies, is that one size does not fit all, and maybe the behavioral change wheel is a good way of tailoring your implementation strategies to your target group, your project group, and your target population. So this is what I wanted to tell you. If you wanted to know more about the Pike 15, you can look at the website. If you wanted to know more about implementing PAIN or Pike 15 in nursing homes, you can contact us, and you can also email me for this. So thank you for your attention.
Thank you very much for that, Marlies. Due to your excellent timekeeping, I think we can go for maybe one question to the floor, if anyone wants to pose a question or a comment.
Yes, there's one.
And we have Chris.
Mike is coming.
I think it's really important for pain assessment. I've recently cared for a friend who was end of life, and she passed away in August. And she had Alzheimer's, but she also had breast cancer. And a palliative care nurse went to the home to do an assessment for her, and she interviewed my friend on her own. And she said to me afterwards, she's not in pain. I said, she's in a constant pain, because the cancer had broken through the skin. And she said to me, and she's eating well. And I said, she hasn't eaten for 2 months. So the importance of having somebody there who knows the individual is vast. And I said, she must not have another assessment without me being there. We'd been friends for 54 years. So you've got to have that background knowledge to do an assessment of pain with somebody who knows the person.
Yeah. Well, this instrument which I show you, this is also like you can use it without knowing the person, and I think that's more an objective one to do. So I think that's in addition to people who knows people, I think that's a good one to add. It's not, like you said, you know your friend, and that's maybe the best assessment. But this is for people who don't know them.
And you only had to look at her face. She obviously didn't do the face-to-face and looking at the reactions of the person. She just went by the verbal answers, which were wrong.
Yeah, agree. Thank you.
Okay, thank you very much once again, Marlies, for that presentation. And we'll now move on to the third speaker of this session, which is Anthony Skerry. Anthony is an academic resident at the Department of Nursing, which is in the Faculty of Health Sciences at the University of Malta. Background in gerontology, geriatric rehab and management, and has a PhD in gerontology that focused on the implementation of person-centred care in hospitals using an inquiry approach. He's also worked for some time as a charge nurse in a geriatric rehab ward, and he's a member of the Malta Dementia Society, Interdem, and also on the Alzheimer's Europe Expert Advisory Panel. So I'll just hand over to Anthony.
Thank you very much. It's a pleasure. Why rehabilitation in dementia? Let's look at my personal background. Basically, I worked for quite some time in rehab, and one of the things that I've noticed working in a rehab setting, in a rehab hospital, is that when persons with dementia used to come, there was always this feeling from some of the colleagues, some of the staff, that it seems like they should not be here. So there was this belief. So obviously, I was always intrigued in seeing what other professionals view about dementia. So that's why I've worked on this scoping review together with my colleagues. And basically, this is basically what I would like to do, go through a little bit the scoping review, but also help maybe discuss or raise awareness about the need to look more critically about the role of professionals and how we perceive persons with dementia when they admitted in a rehabilitation unit. Well, what is rehabilitation? Well, there are several definitions, but it is a set of interventions which help to optimize function and reduce disability for individuals with health conditions, stroke mental conditions, of course, And it is tailor-made rehabilitation interventions particularly are actually very much suitable and suited for persons with disability, including persons living with dementia. There are several justifications for this, and we are seeing this over the past few years, an increase in documents in WHO, Alzheimer's Europe, that focusing on the relationship between dementia care and disability care and the importance of a right-based approach, which obviously gives more impetus, more importance of the role of rehabilitation in dementia. There is also objective evidence. There are studies over the years that have found that it is not true that persons living with dementia are not rehabilitatable, are not able to be rehabilitated. In fact, many studies have shown that with tailor-made interventions, even persons with dementia can be able to rehabilitate it successfully. However, there are still the belief, the perception, that persons living with dementia are unworthy by clinicians to be eligible for rehabilitation services. So that's why the aim of this scoping review was actually to look at perceptions, attitudes, and opinions of healthcare professionals, but also to map what are the challenges and solutions when providing rehabilitation to persons with dementia. So basically the method was a scoping review of looking at identifying questions, identifying relevant studies, reviewing and selecting those studies, charting the data, but also obviously important of summarizing and reporting the results and mapping these results. These were the search strategy which was used, the databases, 7 databases, where these were the keywords, the inclusion criteria. We did focus mostly on peer-reviewed full-text articles, and we tried as much as possible, obviously, to look at studies which focused on opinions, views of healthcare professionals, obviously studies which focused on primary prevention rather than tertiary prevention. So, for example, avoiding of falls were excluded, but we would try to focus on mainly tertiary prevention, so rehabilitation. And this was the methodology that was used in the collation of the studies, identification. So the first articles were read, sections were coded, common themes were searched for broader significance, themes were then reviewed and agreed by authors, and then eventually extracts were identified to describe the themes and charted according to 3 different stakeholders. So what was evident from these studies was that you could sort of map these themes into 3 main stakeholders, which were actually the persons living with dementia and their family members, the healthcare professionals, as well as the organizational services, the rehabilitation services. So basically, this is the PRISMA chart. So we started up with 648. Then we identified, after exclusion, 15 articles, but actually 14 studies, which, in fact, there was one which was part A and part B of the same study, but 2 separate articles. Some of the findings, description of characteristics of the selected studies, most of the time descriptive, qualitative, but there were some cross-sectional studies and mixed method studies. Interestingly enough, most of the studies were in Western countries and in developed countries. A variety of health professionals were sought, so the opinion of various professionals, doctors, physios, nurses, OTs. So you could get a very interesting overview of what healthcare professionals perceived. Interestingly enough, most of these studies focused on persons with dementia with specific rehabilitation needs that had either orthopedic or mobility issues, or one had stroke rehabilitation. So persons with dementia with stroke rehab, there were only 4 studies which did not focus specifically on a rehabilitation focus. And obviously, the question is, persons living with dementia that do not have any of these, why were not studied, or at least, so the persons living with dementia symptoms, do they require rehabilitation or not, of course? So the settings varied as well: acute hospitals, rehab units, domiciliary rehabilitation services, and others, which were a variety of settings. Let's look at some of the challenges, as I said, divided into these 3 main categories. Yes, there are some challenges as perceived by professionals with regards to the cognitive symptoms, with regards to the non-cognitive symptoms, with regards to the multiple comorbidities, including pain and delirium, which obviously makes it challenging sometimes for these professionals. The variability and unpredictability of the disease trajectory, so sometimes it's very hard to know what's going to happen. The lack of knowledge, particularly about rehab, by the family members, and their sometimes high expectations. So some professionals felt that there was a problem there, and as well the complex social needs and delayed discharge. Obviously, an important solution, if we had to call it like that, is the importance of family involvement throughout the rehabilitation process. With regards to healthcare professionals, definitely lack of knowledge. Many studies acknowledged, many professionals in this review and these articles acknowledged the need for better training. There was lack of knowledge about the rights of persons with dementia. And this was obviously an evidence of negative attitudes and as well stigma, even in the way they referred to persons in dementia, with the language even when they were interviewed. Confusion in the definition of rehabilitation and meaningful outcomes. There was a problem with understanding what rehab means, and different professionals had different views of the definition. Healthcare professionals showed ambiguity and complexity. They didn't know. Sometimes there were low overlap, and certain people had even boundaries where they stand. And belief about the incompatibility between rehab and palliative care, which was found in some studies. So where does rehabilitation start and palliative care finish? Is there a need to define or to differentiate? There was also evidence of lack of teamwork, lack of communication, and professional tribalism. So trying to find boundaries. Some solutions, as we said, training and experiential learning as perceived by these professionals. The need of upskilling healthcare professionals, especially when it comes to communication, definitely, and also learning about how therapies, how we can change, we can slow down sometimes the therapeutic intervention. We can facilitate it through other means, by engaging, by making it interesting, by making it by motivating them. Staff consistency was particularly important, peer support and mentoring, and as well interdisciplinary collaboration. When it comes to provision of services, particularly rehabilitation services, there was evidence of stretched resources, which we know about, staff levels, lack of adequate time, rehabilitation beds and community services, unclear and complicated and inappropriate referrals. There was problems with, especially when it comes to referring patients, rehabilitation wards that are not dementia-friendly, persons living with dementia with moderate to severe cognitive, which were not being eligible to rehabilitation services. And there were some countries where, unfortunately, due to the way the insurance system is, persons living with dementia with severe, moderate to severe cognitive impairment were actually not eligible, as well as lack of clear care pathways and evidence-based guidelines, too much focus on patient safety, especially the risk of falling. And this obviously meant that sometimes patients were restrained or had some challenges, obviously, to continue the rehabilitation process. Protocols that discriminate persons residing in residential aged care facilities. So, again, issues of stigma here as well. What are the solutions? Definitely the need to provide flexible, individualized person-centered services, providing safer, but also most important, dementia-friendly environment, we've heard as well this morning, developing rehabilitation activities that are creative, as I was saying, enjoyable and meaningful. So how can we tweak the actual activities, the therapies, to make them enjoyable? Managing risks and planning safe discharge, so the most important risk management here. Redirecting rehabilitation to be more home-based. So we've heard this, we've seen this during COVID time, how we can, for example, provide home-based rehabilitation services which through the use of telerehabilitation or telemedicine. Changing the organizational culture, particularly long-term care facilities, yes, as well as application of technologies and integration of services. To conclude, there are numerous challenges, yes, but there are numerous solutions. There are a few identified studies on rehabilitation, how rehabilitation could support dementia symptoms, irrespective of other comorbidities. Unfortunately, hidden disabilities like dementia are often excluded from accessing rehab, as well as healthcare professionals' misconceptions about rehab. Unfortunately, there is a need as well to identify innovative ways of how to provide rehabilitation to persons with dementia at home through telerehabilitation. Thank you.
Thank you very much, Anthony. And I think we have time for one quick question. If anyone from the floor wants to make any comments, questions, queries, etc. to Anthony. Okay, Thank you very much, Anthony, again.
Was a question?
Was there a question? Sorry, my apologies.
Yes, no problem.
Yep, there's a question over here.
Thanks very much. I'm here, Anthony. I'm over here, the other side.
Yeah.
Thanks very much for hearing about your scoping review. I'm just wondering, because one of the elements sometimes that's included in a scoping review is the consultation, where you might include people who are involved, so maybe the healthcare professionals or the commissioners of services, or it could be people with dementia. And I'm just thinking, because the inspiration was because of the misconceptions of healthcare professionals, have you got plans to actually share your results with those professionals and with service commissioners? Because some of the results would maybe challenge some of those misconceptions anyway.
Can you repeat? Is that a question or sorry?
Yes, sorry. Have you got plans to actually share your results with healthcare professionals and service commissioners?
You mean actual findings that
yes,
found
your actual findings.
No, because the scoping review was actually focused on the perceptions. So the many studies were mainly focused on looking at the views of rehabilitation within. So, but there are evidence where if rehabilitation services are more person-centered, then yes, the outcome would be a better service and more fruitful and enjoyable services. Yes, there were a couple of studies.
Yeah, because you've got the negative and the positive, and I kind of think, well, the negative but the positive clearly has implications, so it'd be quite good for sharing out there as well into practice.
Yeah, I mean, probably that will be another study to look at, the interventions that could improve rehabilitation.
Okay, thank you.
Thanks again, Anthony, for that, and maybe you want to continue the conversation after in terms of follow-up as well, but you might put your hands together for Anthony, please. Now, our next speaker is Annette Kooning, who is going to talk today with regard to... no.
So the one at 3.
I'm ahead of myself. Is Antia Innes, who is going to talk today about providing care to people living with dementia, the views and experience of UK radiography professionals, which is particularly interesting because I know there's been quite a lot of work done in Ireland with regard to training and awareness with radiographers, given the nature of some of those scans, which can be quite distressing in their own mind as well. So I'll hand over to you, Anthea.
So my name's Anthea, and this study was conducted while I was at Salford University, and these were my radiography colleagues, Rob and Adam, and the study was funded by the Royal College of Radiographers. So we actually got the whole idea from this project from people living with dementia. We had an associate panel at Salford of dementia associates, and there was one man who was receiving radiography services because he also had cancer. And that led to lots of discussions from other members about experiences of if they've had a fall, if they were getting an X-ray. And they basically said, why are you not doing any work looking at radiography? Because they'd had pretty bad experiences in general when they'd been getting any kind of radiography diagnostics. So this is separate from any kind of imaging related to their dementia. So we started to have a little look at the literature. We found that there was a gap in knowledge about from practitioners and even less information about patient experiences of radiography too. The clinical guidelines did exist, but they were largely drawing on the experiences from other clinical groups, mainly nursing. And so we decided that we would start off by looking at the experiences of radiographers themselves. There was a nice policy context in terms of the work that the College of Radiographers had already done, and there was also the dementia-friendly strategies about experiences of people in hospital. So we kind of knew that the work had kind of policy support underpinning it. So what we really wanted to do was to explore the lived experiences and perspectives of both diagnostic and therapeutic radiography practitioners when they were providing care for persons living with dementia in the hospital. We used a multi-method qualitative research design. There was 2 phases. The first was online focus group, and the second was semi-structured interviews with the stakeholders who'd been involved in producing the College of Radiographers Dementia and Carer Guidelines. And we approached the analysis using a thematic approach, both within and across the 2 data sets. So to move on to the findings, there's 4 main thematic areas that I'm going to share with you just now. The first is around enablers to support dementia care in radiography departments. The second was how to work more effectively with the care partners of people living with dementia. The barriers to providing quality dementia patient care that the radiography participants had reported to us, and the need for dementia education and training for radiography professionals. So some of the enablers that we heard from radiographers was the need for communication, and they shared some of their approaches to communication that they found really worked. So this is one person talking about speaking clearly and calmly, trying to explain exactly what they're going to do before doing it, providing plenty of reassurance throughout the examination, and making sure the patient feels safe and as comfortable as possible. They also spoke about having specialist support available to them within their teams. So one particular department had dementia friend champions within their departments that all professionals could access in relation to dementia awareness training, both online and face-to-face. And so this specialist training was really important because most of the kind of general radiographers didn't necessarily have a lot of advanced knowledge about dementia or advanced training or advanced skills. So it was important that they had someone that they could go to if they had any questions or queries. Working with care partners of people living with dementia was really seen as crucial. But it was also very difficult. So they found that often the care partners needed just as much support as the person receiving treatment. And they sometimes found that the person living with dementia would have side effects, which made their dementia-related symptoms more difficult, which then had an impact on the carer and the relationship between the carer and the person with dementia. They also talked about pre-visits and that they might not be useful just for the person living with dementia, because in one place they'd started a practice where people could come and visit the radiography department and have a bit more of a sense of what they were going to experience. But they also felt that the care partner might also benefit from that kind of approach, so they were then able to support the person living with dementia more effectively. And that was anything from knowing where to park and to be able to work your way through the hospital to find the correct waiting room, which was also quite problematic. People would often appear in the waiting room in the radiography department stressed before they'd even started things, because it'd been such a palaver to get to the hospital and then find their way through the hospital. They also recognised that the carer could offer really valuable information to achieve better outcomes if they knew the patient well. They would be able to communicate with the patient to be able to help reassure and calm them, especially if they were going in to, get any particular screening. So basically, they were kind of summing up by saying the carer could be the greatest asset, or they could really hinder the process, depending on the needs that the carer also had. And a good carer, in their view, would be able to provide information and assist the radiographer. But a carer who didn't have great rapport with the patient, or who was also stressed, could contribute to greater anxiety. So just to kind of sum up some of the barriers to providing quality dementia patient care that the radiographers that were involved in this study reported. They felt that the management often didn't understand the time commitment that's required for people who are living with dementia. It was very much a case of in-out in terms of the screening, and that wouldn't work with people living with dementia. They would need some more time to be reassured, for things to be explained to them. But management wanted everything to be as fast as possible, get everyone through as quickly as possible. And there was therefore this whole culture of time pressures within the radiography departments, which was really problematic. And they also found that they didn't necessarily know when the person came in if they had a diagnosis of dementia. And so that would make it very difficult in terms of how they would manage that patient interaction. Whereas if they knew in advance that the person had a diagnosis of dementia, they would alter their approach. So people also spoke about the need for more education and training for radiography professionals, both at entry-level education, so for dementia awareness training to be available right the way from undergraduate level and regularly updated, and that students would need to be prepared for the potential challenges as well as the rewards of caring for people with dementia. They also talked about having dedicated dementia training or an appointed member of staff who had more knowledge that they could draw on, and also the need for continuing professional development, because some people might have had some training right at the outset and then very little as their kind of career progressed. So basically, two key points that we found: that there was a lack of education and training targeted at radiographers specifically, and very little around capacity and consent and how to understand that and apply that to people living with dementia, and how to translate some of the very good policy guidance into practice. There was a real gap. And we also found that there was real challenges of achieving changes that would be that the guidelines would suggest should already be happening, but weren't necessarily happening in practice because of the kind of work practices and cultures. So although you had guidelines, it didn't necessarily make any difference in practice. So just to conclude, there's a need for research to further examine and observe the practices of radiographers. We're really keen to see what would happen if we followed patients through from when they entered the hospital right through, their whole patient experience. That's not happened yet, as far as we're aware. There's a need to explore the experiences of people living with dementia and their care partners, just to see what their experiences are. And there is obviously a need for further dementia training and education. If you want to know more, we have published a couple of papers in the last year or two, both in radiography journals and in dementia journals specifically, because we're trying to make sure that, because radiographers often don't read the dementia-specific information, and the people who've got the knowledge about dementia don't necessarily share it directly with radiographers. So we're trying to get this little bit of knowledge translation between those two different audiences. And that's it. Thank you for your attention.
Many thanks, Anthea. And we might go to the floor to see if there are any questions or comments. We have someone in the front. Yep. It's coming. Yep, it's coming.
Yeah, great presentation. We linked back to what we were talking about, Time for Dementia. We've delivered Time for Dementia with radiography students and looked quite specifically at their experiences. And a lot of what you've said correlates, because what they've talked about is that they've learnt about it when they're in their undergraduate, and then they go out on placement and they see the sorts of practice that they wouldn't want to see. So there's, it's just to echo what you said, really, that it's the existing practitioners out in practice who need the help to sort of make the changes or the support with their systems and so on. So
yeah, I think that's a good point. My radiography colleagues have tried to implement more dementia-friendly practices into the curriculum at Salford, but they have then said when they go into practice it's not necessarily what they've been taught. So there is a real kind of mismatch. So yeah. Okay, thank you.
Thank you very much, Anthea.
Yeah, hello.
Sorry, we have one more question, have we?
Yeah, just a second. I would like to add here that really there is a big problem when person with dementia comes into the hospital, and there is not enough knowledge on the side of the staff working in the hospital. So it's not only radiography, but everywhere. And it's important that we talk about these problems. Very often, carers call to our association and they say, my mother is in the hospital, and they call me, take your mother home because she doesn't communicate with us. So there is a big problem in the hospitals, and what we have to do and need to do is raise awareness about dementia also for the staff in the hospitals. That is problem everywhere, no? And often people with dementia, with diagnosed or without diagnosis, they come to the hospital. So what you are doing on radiography is excellent. Thank
you very much. Yeah, I think that's a fair point in terms of across all disciplines, particularly in the acute sector as well. And there's a lot more work to be done there. Maybe we have one final comment before we'll start the final presentation?
Actually, we do not have lots of time left. The buses that will take people who registered for the welcome event will be arriving in about 5 minutes. So we need to go to catch the buses, and they will leave at 6:30.
Okay, so perhaps you can catch up after the formal presentation.
My apologies.
So we're on to our final speaker this evening, which is Annette Koenig from the Netherlands, and presenting on shared decision-making in fundamental care by nurses with acutely hospitalised patients with dementia.
Thank you, and good evening. I can say good evening now, I think, everyone. Thank you for being here still. This is the final presentation for today, and I hope you still have enough energy to listen. My brother told me I had to make a joke or had to dance, but that's not my talent, so I leave it by this. My name is Annette Plantinga. Who is the ones who are still sharp will see that in the program book is another name, but that's nothing. That's because I chose to use my birth name again. I will discuss my study regarding nursing experiences of shared decision-making in daily care by nurses with hospitalized patients with cognitive impairment. And we choose the term cognitive impairment because that also includes all the people who don't have a diagnosis yet. Before we jump into my research, let me explain where I work. I'm employed at the NHL Standen University in Leeuwarden, where I work as a researcher within the TALMA lectorate about living, well-being and care for the elderly. Furthermore, I'm actively involved in the education of future nurses, and I've got a lot of inspiration today. And additionally, I work as a neuroscientist at the Alzheimer's Center in Groningen for 1 day a week. And I mark my workplaces on the map so you can see how far I've traveled. Well, my journey has brought me here today to share the latest findings from my recent PhD project. And to start, I'll provide an overview of what we already know about this topic. Then we'll dig into shared decision-making, explaining our research objectives and presenting insight into our methodology. Lastly, I'll discuss the findings and highlight the lessons we can learn from our study. What is known? Shared decision-making is a critical aspect of person-centered care and a preferred approach for all patients, including those with cognitive impairment. And it is widely accepted for all patients to receive care and treatment consistent with their unique preferences, goals, and choices. Care and treatment dilemmas often arise because patients have multiple health problems, and in addition, it is difficult for people with cognitive impairment to make decisions because they do not fully understand the relevant details. In this situation, nurses are essential to provide guidance. And as the cognitive impairment progresses, the involvement of patient relatives becomes increasingly important. But research has indicated that for patients with cognitive impairment, the involvement in decision-making is essential as the decision-making itself. However, nurses often misunderstand the desire of these patients to participate in decision-making. Well, what is decision-making? I'm not sure if everyone knows this concept. Shared decision-making is a dynamic process with over 40 models, most of which include the core elements as outlined by Elwin and Vermunt. These basic parts consist of the goal team talk, the goal option talk, and the goal decision talk. And all these components are critical to the shared decision-making process. The goal team talk focuses on supporting patients, suggesting options, and understanding their goals to guide decision-making. Goal option talk involves comparing alternatives, using risk communication principles, and goal decision talk includes making decisions that are consistent with the patient's informed preferences, using the experience and expertise of the healthcare providers. And the goals identified in the early stage of the process provide a common ground in each such subsequent step and focuses on relieving symptoms, improving function, or maintaining independence in daily living. The main objective of shared decision-making is to strengthen the caregiver-patient relationship, improve the quality of decisions, and contribute to better healthcare outcomes. The aim of our study is to explore shared decision-making in the context of daily care in acute hospitals. I already told that, explicitly focusing from the viewpoint of nurses. And our research aim, our objectives are to describe nurses' practices and perceptions of shared decision-making in the daily care of hospitalized people with patients with cognitive impairment, and to describe how nurses consider the cognitive impairment of patients when making decisions together. Well, we had a qualitative study using a descriptive, interpretive, and phenomenological approach to gain more insight in nurses' experiences, and we interviewed nurses about these experiences and tried to learn more about how they make these decisions, so we could learn from them. Our interviews were recorded and analyzed using Colizzi's 7-step method, and we kept a log to ensure rigor and used criteria such as credibility, transferability, reliability, and confirmability to guarantee accuracy and trustworthiness. During our research, we interviewed 17 nurses. They were on average 39 years old and had 15 years of nursing experience. They worked in 14 different wards across 11 hospitals. We included representation from different types of hospitals. university hospitals, non-university teaching hospitals and regional hospitals. And the clinical settings varied, including surgical and non-surgical wards and outpatient clinics. Nevertheless, the majority of nurses worked in an internal ward. We identified 5 themes. The first theme was shared decision-making in daily care. That was about how shared decision-making is applied. The second one is the nurses' perceptions and competencies on how nurses perceive and manage shared decision-making. The third one are the nurses' roles and advocacy on the changing roles of nurses and their advocacy efforts. The fourth one is recognition of cognitive impairment and its impact regarding how nurses recognize and manage it. And the fifth one is interventions to support shared decision-making, covering strategies and interventions to facilitate shared decision-making. This slide illustrates how these themes are related to the research question and the sub-question. And the first 3 themes relate to the first sub-question and the last 2 to the second, as you can see. Now we'll dive in each theme. First, shared decision-making in daily care. It was described as an iterative process focusing on determining the most appropriate care at that time through active consultation with the patient with cognitive impairment. Nurses didn't apply the steps of shared decision-making. But regarding complex and multidisciplinary decision-making, the nurses gave some nuances of their own role. In the GOAL team talk, nurses made minimal mention of use of GOAL talk because they often focused on managing the specific disease or condition of which the patient with cognitive impairment were admitted. And patient involvement varied in this step. The option team talk, nurses actively explored and discussed various medical treatment options, providing comprehensive explanations and informed recommendations to both patients and their family members. And in the GOAL decision talk, this step was often conducted in family meetings, sometimes following multidisciplinary team discussions, and relatives played a key role in making decisions about treatment and interventions. Regarding nurses' perceptions, it was very striking that half of the nurses felt incompetent using shared decision-making with these patients and their relatives. But the nurses recognized the importance of shared decision-making for patients with cognitive impairment because it is patient-centered, holistic, and it promotes dignity. They believed that shared decision-making led to improved care, higher patient certification, and better medication compliance, and fewer readmissions. Nurses had positive experience regarding the use of their expertise in cognitive impairment and negative experience with decision-making about treatment continuation. Nurses felt the treatment was often continued too long and discussion about non-treatment or palliative care were not initiated or were initiated too late. Secondly, awareness of the patient's perspective could be improved. Nurses mentioned having different roles in shared decision-making. They were facilitators, and they were essential in facilitating the process by supporting patients and families. They organized the family discussions and ensured that relevant information was available, known, and accessible to other professionals. And they were also available to explain and answer questions. Nurses acted also as intermediaries between patients with cognitive impairment, their family members, doctors, but always representing and promoting patients' interest. And finally, nurses identified their role as patient advocates when consulting with different disciplines, including the multidisciplinary meetings. And patient advocacy was a recurring theme among nurses regarding patients, and occurred in various scenarios. Nurses were often confronted with difference between the needs of patients and the priorities of others, including those of their relatives. To account for shared decision-making, it is very important to recognize it. I don't have the time to tell you, but we did a very interesting study about recognizing cognitive impairment in a hospital setting, which showed, thank you, that it wasn't recognized in almost half of the situations. Nurses recognize cognitive impairment by consulting relatives or use their intuition. And they saw it in the behavior when there is a lack of insight in the patient's illness, change in behavior and inconsistent behavior. And they pointed out that cognitive impairment can affect shared decision-making in communication problems. Limited cognition and comprehension mean that information may not be fully understood. These challenges can cause delays in shared decision-making and also may hinder or limit patients' ability to participate. Nurses report that cognitive impairment can significantly impact the patient's recovery process. For example, because certain tests or treatments may not be available anymore. Nurses use several interventions to address cognitive impairment. First, reducing the number of options and sometimes providing more guidance. They involve the relative to support and represent the patient. They acknowledge the feelings of patients because patients often experience a loss of options due to their illness, which makes them sad or anger. The fourth intervention is adapting communication techniques by adopting a calm tone, which I don't have now, avoiding medical jargon, giving information in manageable chunks, and attuning to the patient's emotional state by considering factors such as agitation, anxiety, and fear. In addition, nurses emphasize the need of timing, the optimal moment of shared decision-making. In conclusion, nurses do not feel competent to use shared decision-making with patients with cognitive impairment, and the involvement of relatives is vital to facilitate effective communication and maintain autonomy, and nurses fail to discuss goals, including initiating more research is needed in the hospital setting. My take-home message is empower nurses to engage in shared decision-making, including with patients facing cognitive impairment. Thank you.
Thank you very much, Annette, for that presentation on SDM and the role of the nurse in that as well. I would offer maybe one quick question. I know I'm going to be in trouble with the bus driver, but I think if anyone has a question, maybe they might put up their hands. Okay. So finally, maybe put your hands together again for Annette for that presentation. Thank you.
Thank you.